that's near and dear to me. So thanks for coming to this morning. We're going to talk about chronic pain, patients with chronic pain that's on opioid therapy, and I'm sure all of you have a varied panel of these types of patients. So disclosures, Linda and I do not have any disclosures. We're not rich enough. Learning objectives. So first step is I'm going to review the guidelines for safe opioid prescribing at IMA. There's copies of the guidelines floating around. Sorry, we try to save some trees, and so we only made 8 copies. So please share with your neighbors if possible. And then Linda is going to take over on how to identify how to order and interpret urine drug testing. Plus, there'll be a handout for that, which we'll pass out soon. Just reviewing the IMA guidelines today. Just wanted to give a plug, and contribution is made mostly from a lot of these guidelines came from national guidelines, but was collated and prepared by the IMA Opioid Committee, which Dr. Fishman, Dr. Wang, myself, Dr. Eva Waite, and Carolyn Brown, MP, is part of. So this was a collective effort. A lot of it, as I mentioned, was collated from information that we sourced from elsewhere, expert opinions, national guidelines. The CDC guideline for prescribing opioids for chronic pain 2016 was sort of a fundamental guiding force for this. Very interactive and succinct and comprehensive website that we found useful was mytopcare.org. And then if you guys remember, in July, you guys went probably through the scope of pain courses, the two units that needed to be done in order to qualify the mandatory opioid prescribing guidelines from the New York State, right? Everybody? Okay. All right, so let's start off with the case. So Miss JR's 55-year-old lady presents to IMA with a complaint of lower back pain. It's been going on for about 2 years since an injury at work. She's been on disability. She's tried a lot of things: physical therapy, acupuncture, aquatherapy. She's tried also a lot of medications, including Tylenol, naproxen, ibuprofen, topical creams, and hasn't really found much relief with any of these treatments. Once the physician gave her oxycodone 5, and she took it about 1 to 2 tablets every 4 hours as needed, along with gabapentin 300 milligrams 3 times a day. Unfortunately, the prescriber left or something happened, and she stopped getting those opioids and has had trouble finding someone to give her the oxycodone again. She notes that aquatherapy was minimally helpful, and then oxycodone was quite helpful. Her pain right now in clinic with you is 10 out of 10, and she's unable to get outside her apartment and walk her dog due to the pain. So how would you approach this case? I think historically at IMA we've sort of been doing it based on preceptor preference and also our comfort level. Going forward with the IMA opioid guidelines, we'd like to make it a more standardized approach to these type of patients. So before starting, these are some considerations that should be taken into consideration. So review and try non-opioid medications and complementary therapies. Has the patient exhausted other non-opioid therapies? Is opioid therapy going to cause more harm to the patient or create more benefit for the patient? Does the patient have any risk factors that might make she or him more likely to misuse the opiate? So comprehensive history of prior substance use, any indication for prescription misuse in the past, and concomitant mental health disorder. Age also, younger patients, meta-analyses, younger patients tend to get in trouble with opiates more so than older patients. And then obviously we need objective data. Does the patient's story check out? So using iStop and urine drug testing just to confirm the patient's story. Because as my residents know, my mantra is trust but verify. And so it's always good to have objective data. This came from my top care as well. This is a basically stepwise approach approach to pain management, starting off with more benign medications, and then you see step 5 is opioids, so last resort for pain management. All of these also wanted to reiterate that they can be used in conjunction with each other, and there's often a synergistic effect as well. So it's not one exclusively and then go down the line, but you can try multiple in each of these steps before moving on to the next step. Okay, and then assessing the benefits versus the harms of the patients of opioids for patients. Obviously, opioids are very popular because they are a very powerful analgesic medication. There's been studies that also show that opioids not just provide analgesia, but also provides a euphoric effect for patients, even when used just for pain. And then with analgesia, the goal of opioid therapy is to relieve pain for our patients, but also to increase the functional status of our patients. A lot of our patients come in saying, I can't do X, Y, and Z because of my pain. And so as part of our goal in addressing their pain is to identify SMART goals, which stands for specific, measurable, action-oriented, realistic, time-sensitive goals that we use to set the stage for why opioid therapy is indicated. Then there's the PEG tool. This was introduced in the scope of pain, but essentially is a objective screening tool to see how pain is impacting the patient's functionality. So PEG stands for P is in pain. What is the patient's pain level currently? E stands for enjoyment of life. How is the pain impacting the patient's enjoyment of life? And then G stands for general activity. So how is the pain affecting the patient's general activity on a weekly, daily basis? And so you want to get this as a baseline and as an ongoing assessment through treatment. So you want to get baseline and see if opioid therapy is actually helping to improve the patient's functionality and general enjoyment of life and pain scores through treatment. Okay. Obviously, we wouldn't be having this talk if opioid therapies is just great and there's no potential harms. But as data in the last 20 years have come out to show that actually opioid therapy is associated with a lot of risk. First of all, sedation and respiratory depression. We know that we've seen it in the emergency room. We've probably seen it in the inpatient side, but this is a real risk as in the outpatient side as well. Because of opioid tolerance, we keep escalating the dose. Just keep in mind that sedation occurs before respiratory depression, and that it's a vicious cycle with anybody with a sleep apnea or a sleep disorder. So opioids worsen sleep apnea, and having sleep apnea on opioids increase your risk of respiratory depression and complications. Constipation is another well-known side effect of opioids. Physical dependence, worsening pain, and then rarely allergies and organ toxicity. Okay. So after thinking about your patient's functional status with the PEG tool, checking I-stop, checking the urine drug test screen, and everything sort of weighs in the favor of benefit versus harm, and you decide to start opioids on your patients. This is sort of a stepwise approach to thinking about how to discuss starting opioids with your patient. So number one is coming to an agreement on the problem, so addressing specifically what pain that the opioid is going to treat, right? So low back pain, chronic knee pain, not just like your body hurts, I'm going to take an opioid, right? Just have to be very specific indication for the treatment. Identifying treatment goals, again, going back to the SMART goals, so identifying, we're giving you opiates so that you can walk your dog more often, or you can get out of bed and go to work, being very specific and measurable and timely. Present opioids therapy as a test. This is not like an indefinite thing. We're going to try it out for a short period of time. If it works, we'll continue it. If it doesn't work, we'll modify the treatment and we might stop the opioids. Reviewing the risks with the patients, everything that we just mentioned before. Reviewing the patient-provider agreement, otherwise known as the pain contract with the patient. The opioid committee has recently updated the PPA. We've uploaded it into Epic. No, we'll upload it into Epic. There are definitely paper copies in each of the firm preceptor rooms. So reviewing the PPA and having the patient agree and sign the PPA. Next step is to review monitoring practices. So once you start the patient on the opioid, what are you going to do to make sure that adherence and use of it is appropriate? And then set up the next visit. So definitely before the patient leaves, try to have a follow-up appointment within 2 to 4 weeks from starting the opioid to make sure that the patient is using the opioid appropriately and that there is effective analgesia. Now, choosing an opioid, there's not a lot of great guidelines around this, and there's also not a lot of head-to-head studies, and there's not one opioid that's immediately superior to another opioid. But consider, there's some things to consider. So, especially patients' exposure to previous opioids. Some patients might have a preference based on their previous exposure. Also, your exposure to opioids. If you've never dealt with Dilaudid in the past and you don't feel comfortable with it, definitely don't go with something that you're not comfortable with. Consider short-acting if it's an acute versus subacute pain, or long-acting if the patient's going to have pain and you anticipate that the pain is going to be a little bit more long, more chronic. Other considerations, so medical comorbidities to take into account. Prolonged QTC, their creatinine, their liver function, if they've ever had seizures or withdrawal cephallos in the past. There's a helpful chart that we've linked into this PowerPoint that talks about each of the popular opioid therapies, their side effects, their dosage, etc. I'm not going to show it today, but it is in this link, and this PowerPoint will be emailed out. It's also, there's a link in the document that we're going to email out to everybody as well. In general, every single guidelines is basically the mantra should be start low and go slow, right? So you want to start off at the lowest effective dose for your patient and slowly increase as needed. And then most important, I think, is also try to avoid prescribing more than 50 morphine meal equivalents, and we'll talk about morphine meal equivalents in a second, but try to avoid more than 50 total for all your patients. So long-acting, short-acting, add it up, and if it's a little more than 50, just make sure there's a little caution bell in the back of your head. The reason we chose this number is because there's been meta-analysis that shows that with increasing NMEs, there's increasing risk of overdose events as well as an overdose death. And at around 50 NMEs, the odds ratio goes from 1.23 for anything less than 50 to around 1.9 and 2 for over 50. Over 200 NMEs, it's around 3, so the odds ratio is 3 times risk of overdose death. So definitely cap 200 and 50 is caution level. Okay. How to calculate NMEs. There are several useful calculators online. We recommend the Oregon site. There's a link that's going to be available through the PowerPoint, but definitely not opioids are created the same. So morphine is the benchmark, and then everything else is compared to morphine. Keep in mind fentanyl is 2.4, but it's in micrograms per hour, so the unit's a little bit different from all the other forms of opiates. And then oxycodone, which is the most popular form, is 1.5. And because of the conversion factors, the NMEs go up really quickly. So if you consider you give someone oxycodone 5 milligrams 4 times a day, that's 20 milligrams total of oxycodone. That comes out to be 30 NMEs. It's really confusing math in my head. But if you do 10 milligrams of oxycodone, so you double the dose and you give them 4 times a day, so that's 40 40 milligrams total of oxycodone, which comes out to be 60 MME. So now we've gotten over that suggested benchmark cutoff for the MMEs, right? So as you can see, like, your dosage is really important, and calculating the MMEs is important. Okay. So let's talk about the case again. So long discussion of risk and benefits. You agreed to prescribe oxycodone to JR to help with her pain. You identified that the goal is for her to walk her dog more often, which is how she finds enjoyment in her life, right? So, and you also recommend physical therapy for that. You sign the PPA. You go over how to take her opioids, the monitoring, and you recommend 15 milligrams long-acting because her pain is going to be chronic, 15 milligrams twice a day, and you increase the gabapentin scoring. Remember, there's a synergistic effect. I mean, there's just some data to show specifically between gabapentin and oxycodone. So you want to try to maximize the non-opioid therapy and while you're doing the opioid therapy. And then you set up a follow-up appointment in 2 weeks to assess her pain on this new regimen. So how to follow up patients that are on chronic opioids. So we suggest, I know this is going to be time limitations, but if necessary, maybe set up a separate appointment to address the pain and the opioids. But we suggest that at each follow-up appointment, asking the patient how they're taking, like specifically, are they taking, what are the hours that they take it? Are they taking with food? Are they taking with other medications? How do they feel afterwards? Assess the benefits risk, go through the PEG scoring assessment again, their functional status, review side effects. Does the patient have constipation, over-sedation, other side effects? Are they meeting their social and mental health issues? If they have a concomitant depression or anxiety, are they going to psychiatry and seeking therapy appropriately? And then gather objective information. Again, stop urine drug testing. And then Dr. Wang is going to talk extensively about the urine drug testing in a second, but I've noticed that we have been getting a lot better with doing stopping, but not so much better with the urine drug testing. So just making sure that gets done. Clinical signs for side effects and adverse reactions to the opioids. If the patient is nodding out to you in clinic, like each time you see this patient, and just kind of be wary about that, okay? And then communicating next steps. So monitoring for adherence, misuse, and diversion. As we said, the urine drug testing is very important. We recommend every 3 to 6 months for your very stable patient, low-risk patients. But if there is a patient that's a little bit suspicious or a patient that you are escalating the dosage for, we recommend getting the urine drug testing more frequently. During the physician drug monitoring programs, aka iStop, how many here has a working iStop? A lot of the residents' hands are not up. Okay. I think that if your iStop's not working, ask a preceptor or ask someone who has a working iStop because it's really important. I think we generate reports once a month, right, Eva?
It comes out every month automatically.
Yes, once a month automatically about who's giving prescription opiates without iStopping. So it becomes a pattern.
You have to put in .iStop.
Yes. 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 So that's how the report is generated.
Say .iStop and it's
all right, and then pill counting. We currently don't do a lot of this at IMA, but if instituted, it could be very helpful. It's basically to confirm medication adherence and minimize diversion. It can be scheduled or a surprise, bring me your pills, I want to see them today, visit. And then the other point we wanted to make is, whether or not to prescribe 28 days versus 38 days. So 38 days means 30 days, 30 days means that every time that they stop, it's going to be the same day of the week that you last saw them. So you can sort of more reliably schedule the patient's follow-up. So, like for example, every Tuesday morning, Miss JR is going to meet with me once a month to 28 days.
28 days.
28 days. That's right. Because that's what we do for Hep C medication.
And it'll never be a weekend.
Yes. So 28 days will always fall on the same day that you prescribe the medication. 30 days means that given the month thing, that you might actually have the patient run out a couple days before or after the follow-up appointment. So just making sure that you count it out as you're refilling it for your patients, that the follow-up day does not fall well after their pills are expected to run out, because then we'll have phone calls, patients stopping in clinic, angry patients, etc. Okay, talking points for opioid overdose prevention. So this is a conversation I feel strongly that many providers should be having with their patients, especially if they're on 50 or more morphine and pill equivalents of opioids. There's risk factors for overdose, reviewing those with your patients, changing tolerance. So patients that either have just been recently incarcerated or recently went through a long hospitalization and didn't get their normal opiate dose, and they come out, just know that their tolerance might be different. And so being mindful to not go back automatically to the same dose as before. Using with other drugs and alcohol, the expert screening is going on right now, and it's going to be more pervasive in 2018. So being mindful of those results of that, with the opiate usage. Fentanyl contamination is an ongoing issue throughout New York State. Recently, since we started the new drug monitoring drug test, I found 2 patients with unexpected fentanyl in their urine. Okay, so it's getting in there, and it's in our patients' population. Signs of overdose, reviewing that to our patients. If you talk to them, there might be a lot of misconception about what overdose means, and then just making sure that their idea of an overdose is in line with what's physiologic. And then making sure that they know how to react to an overdose once they identify an overdose. So calling 911 is always a step that I emphasize, because a lot of times patients are scared or patients are worried that they'll get in trouble. The Good Samaritan law overall protects anyone that's overdosed and anyone that calls 911 to report. They can feel that they're okay if someone calls 911 or if they call 911. There's some small caveats which we'll talk later, but anyways, and then naloxone kits being distributed in IMA. You can also prescribe naloxone. Indications for anyone at risk for overdose, particularly anyone with MNEs of 50 or more. Family and friends who are concerned, anyone who asks. And then where to get naloxone kits. So now each firm, we're in the nursing station, there's a blue Rubbermaid box with kits in it, so naloxone kits. You can ask the nurses to give you one, or you can ask the nurse to do the training for you if you're not already comfortable doing the training, right? And then once in a while, a couple times a month, we're going to have more events in which the medical students are going to come to the waiting area and provide naloxone education, as well as distribute the kits to patients that are interested. Okay? We'll try to email you guys these dates, but in this past week, I think last Friday and this past Monday, we had 2 events and they were very successful. I think we passed out 18 kits the first day and then 13 kits the second day. So if you see like a group of medical students in the lobby, this is probably what they're doing, okay? So language when our patients are not meeting goals and are having or experiencing side effects from opioids. It's an uncomfortable conversation. Sometimes the patient gets defensive, etc. But these are some just suggested language that we can use. A lot of it is emphasizing the risk and the benefits of the medication. So the risk outweighs the benefits, or the safety for the medication. So, for example, this opioid medication is not helping you accomplish the goals for the pain medication that we talked about. It is causing side effects. I'm worried about your safety. We may not continue this therapy, right? All right, so case part 3. JR is following up for 3 months. She's been doing well. She's coming in for routine follow-ups. Her urine drug testing has been appropriate, but she reports to you that in the last month or so, she's been using a little bit more of her medications due to the winter pains. Right? In order to stave off withdrawal symptoms, because she's using more, she's running out quickly. She's been borrowing some extra oxycodone from her friends and neighbors, and she wants you to increase her dose. So how do you approach this patient? So she's been having some. She has self-titrated and denies any side effects, so no increased sleepiness, and then it has improved her pain throughout the day when she walks her dog. So ways to consider thinking about this case right now. So aberrant medication taking behaviors is obviously something that we take very seriously. It's often very concerning and causes a lot of conflict in the patient-provider relationship. But just keep in mind that there's multiple other causes for why patients might be taking more of their medications. So disease progression, so is the osteoarthritis getting worse? Is renal disease getting worse? Poorly opioid responsive pain. Not all pain is going to respond effectively with opioids. Withdrawal mediated pain. So is the patient not taking it appropriately throughout the day? So she's waiting too long between her doses, so she's getting withdrawal, and it goes into the cycle of analgesia, withdrawal, pain, and then analgesia, withdrawal, pain. So just assessing how the patient's taking it. Opioid tolerance is something that we know about, and then opioid-induced hyperalgesia, especially for patients that take chronic opioids for a long time. And then just considering what is opioid use disorder and whether or not the patient falls into that diagnosis. So just keep in mind that the DSM-5 carves out a special exception for patients that are on prescribed chronic opiates for chronic pain, right? That tolerance and withdrawal by itself does not merit getting an opioid use disorder diagnosis. If you're prescribing opiates and they're taking it for chronic pain, there has to be something else to their case, right? And so we want to focus on the 3 C's: loss of control. The patient feels compelled to use the medication, and that they continue to use the medication despite side effects and established harms. And then need to look for a pattern. So an isolated event may not necessarily mean that the patient's developed an opioid use disorder, but if it happens repeatedly, and you need to start considering this diagnosis. Okay. So this is just some concerning behaviors. It goes from concerning to like very, very concerning. Requests for increased opioid dose, requests for specific opioid by name, like it's Dilaudid only works for me, not Percocet, not oxycodone. Non-adherence with other recommended therapies. You sent the patient to PT like 10 million times and never made it. Running out early. Resistance to change therapy despite adverse effects. Deterioration in function at home and work. I think these last 3 is major red flags that should be going off. So non-adherence with monitoring, so they're not coming in for pill counts, they're not giving you your urine, or they're refusing to give you urine. Multiple lost or stolen opioid prescriptions, and then illegal activities. Not so much right now because of the electronic prescribing, but forging scripts, selling opioid prescriptions, calling pharmacies and saying that you've already prescribed X, Y, and Z when you didn't. So how to manage aberrant behavior in our patients. Just focusing, just trying to indicate to the patient that we're concerned about their care, we're concerned about their safety. Also emphasizing that based on the current evidence, there's no benefit to the treatment. It's actually causing more harm to the patient. Add on non-pharmacologic non-opioid therapies. Add also non-pharmacologic therapies such as acupuncture, aquatherapy, cognitive behavioral therapy if necessary. Add breakthrough medications. Opioid rotation is a concept that's been suggested in scope of pain, where you try to change to a different opioid to see if the patient has a better response to that. And then referral to pain management. for further help. If it's an addiction, stay in the risk and benefit mindset. Again, just explaining to the patient what's going on and why you're concerned about their behavior. So reviewing their behavior and all of their data with them and explaining why that concerns you. Obviously making sure the patient comes in for closer monitoring. If the patient's been doing every 3 to 6 months visit with you, making sure it's now more frequent, like every month or every time they fill their prescriptions. Remember that this is a chronic pain and addiction are both medical disorders, so trying to address both at the same time. And then just reiterating, I like to use the broken record method. We're reiterating each time that I don't feel comfortable or I cannot responsibly continue prescribing opiates as I see that it's causing you harm, and then listing out the harms to the patient. Always refer to the addiction treatment if it is a true opioid use disorder, so buprenorphine or methadone. Email REACH, #REACH. This is the substance use disorder clinic that I and Linda is running. And then diversion. So if the patient has clear signs of diversion, you really have to start addressing that like immediately. It is a legal liability. You've heard about all of the reports of like doctors being caught for pill mills and going to jail because they prescribed 300 prescriptions of oxycodone in the past year, right? So it is, if we know that the patient is doing something illegal and we are complicit in it, that is a problem. So how to stop opioids when we have good, clear evidence that it is harmful to our patients or the patient's diversion. Assessing benefit, assessing illegal activity, assessing harms. If they have a substance use disorder, this is a clear indication to start tapering off opioids. If the patient's unable or unwilling to follow monitoring requirements, right? And then just keep in mind that when you're talking to the patient, just emphasizing that we're stopping the opioid therapy, but we're not stopping your care, right? We're still going to be doctors for you. We're still going to try to manage your pain, but we're just going to do it differently. We're not doing the opiate route anymore. Okay. Again, more language to keep in mind, especially if the patients that get becoming a little bit defensive, belligerent, just repeating over and over again, I cannot responsibly prescribe medication to you that I see is causing you harm. Okay. Okay. And then the act of stopping opioids, how to taper patients. First, assess the degree of physical dependence. If there is clear evidence that the patient is not taking it and is diverting the medication, for example, my patient who's getting oxycodone from neurology and both of her urine toxins in the last 6 months have been negative for everything. There's probably very unlikely a degree of physical dependence. So you can stop the prescription right away without any sort of taper. However, if your patient's been taking the medication for 10 years, you might have to consider a longer protracted taper for that patient. Okay. How to taper. So it's an individualized decision. Obviously, counseling the patient before you start tapering is very important, setting the stage, firing warning shots repeatedly. Sometimes you might need a couple months lead time to get the patient to be prepared to taper. Being very clear about how you're going to taper the patient, so making sure that there's an agreement about the tapering process. Making sure that the patient has prescriptions available for when they have withdrawal symptoms, so Limodal for diarrhea, or antispasmodics for cramps for when they have withdrawal. There's also suggested opioid tapers providing the link from My Top Care. That's going to be in the PowerPoint that we email out. The general rule of thumb is to taper by 10 to 20% every 1 to 2 weeks. You can do every 1 to 2 months if you're trying to go for a longer taper, but it's usually around 10% of the total dosage. And then using longer-acting agents to help with breakthrough symptoms when tapering off of using shorter-acting agents for breakthrough pain when tapering off longer-acting agents. Okay. And then if there is a particular problem with a patient or if the patient is particularly resistant to tapering, feel free to reach out to the IMA Opioid Management Committee. Either email myself, Dr. Fishman, Waite, or Wang, and Carolyn too, and anybody, and we will discuss it at our committee and help support you. Remember, there's also adjunctive therapies for the pain. We're not abandoning the patient's pain. We're just thinking of more creative ways to address their pain. Non-opioid prescriptions, SSRIs, SNRIs, tricyclic antidepressants, complementary treatments such as acupuncture, yoga, if their insurance pays for it, and then therapy counseling, especially if they have a concomitant psychiatric disorder. Please make sure that they're actually seeing a psychiatrist to get on the proper treatment for those disorders. Okay. And then this part, Linda will take over.
So I'm just going to go a little bit more quickly so we end on time, but you can certainly also just questions about anything that comes out. So going back to your case, so JR has been stable on a prescribed dose of oxy and gabapentin, and it indicates that her functional level has increased moderately, and she's pretty happy with the meds that we're prescribing to her. She's adamant that she's only using what she's prescribed and no more. However, she just started seeing a private psychiatrist for chronic anxiety and insomnia, and they prescribed her new medication to help her sleep. She doesn't remember the name. She thinks it ends with a pin or something like that. And then she also realized that she gets the best sleep when she takes a little bit of brandy before bedtime, and she feels very refreshed and is grateful to you and your psychiatrist. So this is a whole separate talk. We recognize that, but just very briefly, I just want to talk a little bit about benzodiazepines and marijuana, THC, when co-prescribed with opioids and what to be concerned about. And alcohol I'm not going to touch on, but I think very similar is a substance to be concerned about when your patients are using it at the same time. So we all know this, but benzodiazepines increase the risk of respiratory depression and overdose, especially when co-prescribed with opioids. There's a case cohort that showed there's a quadrupling of overdose death risk when prescribed together. So as much as possible, we should avoid prescribing them together. And this is in line with CDC's guidelines that were updated in 2016. Benzodiazepines should really just be used for short-term treatment with a plan for longer-term non-benzodiazepine therapies. And it's really not first-line treatment for anxiety or insomnia, as you all know. And very much the risks are physical dependence, withdrawal, misuse, and also a development of a substance use disorder. The other treatments that everybody probably is aware of include CBT, SSRIs, SNRIs, and other relaxation techniques, yoga, exercise. So it's important also to recognize this as a problem in many of our patients who are prescribed opioids. And ISOP can definitely help with identifying patients who are also getting co-prescribed Valium or Xanax. And some of your patients may also be buying Xanax off the street, just FYI. And then you really, when you're considering taking it, it's very important to not stop it immediately. And the general recommendation is about 25% every 1 to 2 weeks. And we have a link to a more comprehensive guideline on how to taper specifically. Marijuana and THC. So it's used for chronic pain and spasticity, although there's limited evidence. As of now, there are 29 states, including DC, that have medical cannabis laws. And this includes New York State, which enacted it in 2014. Really, patients need to register, and it's very expensive. And so for a lot of my patients, I find that it's an unrealistic option for them. It really only pays for liquids and oils for vaping and inhalation, and also capsules for oral administration. It's a 30-day supply, and it's really cash only. Credit cards don't usually allow for purchasing of medical cannabis. Just so you know, what does the CDC say about it? So they actually they don't say much about like when people are using marijuana with opioids, but they do make a note that clinicians should really not test for substances for which results would not affect patient management, and for which the implications are unclear. And so many experts actually say there might be uncertainty about the clinical implications of a positive urine drug test for THC. And They also make a strong recommendation that clinicians should not dismiss patients from care based on a urine drug test result, because this could constitute as patient abandonment. And it could push potentially the patient to obtain opioids from an alternative source that could be more dangerous. And I want to strongly just highlight that we have THC in our screening panels. And so when you're ordering them, and I'll talk about them in just 1 second, just know that it may show up positive, and just have that in mind when you're thinking about ordering these tests for your patients and how to counsel around it. Clearly, if the patient meets the definition of a marijuana use disorder, that is a significant problem and it should be discussed. And if that is the case, then I would talk about their opioid therapy and consider discontinuation if there is a loss of control and there's more harm than benefit. But if it comes up positive and they're using it intermittently, it may just be appropriate to have an honest conversation. And if their opioids are greater than 50 or 90 or 100 MME, then I would consider tapering the opioid a little bit for safety. This is a graph from a study, an ecologic study that was published in 2014, which essentially looked at states with medical cannabis law and states without a medical cannabis law. And it looks at age-adjusted opioid analgesic overdose mortality. And you can see that between the years of 1999 and 2010, the rate goes up for both states with the law and without the law. But you can also see that the top line is states with a medical cannabis law, and that is plateauing between 2009 and 2010. It's an ecologic study. It just describes an association that is possible, but I think it has significant policy implications. So this is also another talk, but just very briefly, buprenorphine for chronic pain. So if your patient has an opioid use disorder and is a good candidate for office-based treatment, it may be an option, and you should definitely email myself and Trang. If there's no clear opioid use disorder diagnosis, but they have high-risk opioid use, such as a history of high-risk opioid use, obtaining it from others, and some of the other red flags that Dr. Wu already talked about. And if there's poorly controlled pain, tolerance, or opioid-induced hyperalgesia, or poor function on full opioid agonists, you can consider buprenorphine. So again, please refer the patient if you think they may be a candidate to us at REACH. And just a note that insurance coverage for buprenorphine/naloxone, the co-prescribed, is much easier when the indications are for opioid use disorder. But there is a buprenorphine monotherapy, which comes in a tablet and also a transdermal patch that is available. And that actually doesn't need an X. You don't need an X number to prescribe that. So some of the in-clinic tools and resources. So all the guidelines, some of you have it, will be placed in precepting and will also be emailed to everybody here. Very soon, hopefully, will also be on the IMA app in an abbreviated version. There's a urine drug testing guide, which Trang will hand out, and I'll go through. And we have made epic smart phrases for you to use with your patients on chronic opioid therapy, which I'll show you in just one moment. The patient-provider agreement will be in the letter section, but for now it will be printed in the precepting rooms. And then provider reports, which we talked about, will be sent out soon. And we're clearly all taking suggestions. This is a sample of what a smart phrase looks like. And so it's just like .ima opioid initial and .ima opioid follow-up. I will share it with everybody shortly. And it just goes through, like, at each visit, what are the goals to address medication review, which includes when their last RX was filled, how many pills they brought in, if they brought it in, current non-opioid treatment, side effects, and then the PEG score. So we highly encourage providers to use these at every visit. I will explain the urine drug testing guide in 1 second. Follow me up here. And then we're going to keep a registry of all the patients at IMA who are on chronic opioids, and we will send out provider reports. It'll be listed as MMEs greater than 50 or MMEs greater than 90. It will also include co-prescribed benzodiazepines. And then once you receive a report, please review and ensure that your patients have an updated provider agreement, patient-provider agreement, that you are obtaining regular urine drug screens, and that you're really assessing the benefit and the risks and function at each visit. These are other online resources, which we've already talked about. And then, so urine drug testing. So, why do we do it? So there's data to suggest that when done successfully, it can identify undisclosed drug use. About 10 to 30% of patients were positive for reported drugs in one study. And then in an HIV cohort, almost 3/4 of patients with a positive urine did not disclose drug use. It can also confirm adherence to prescribed opioids, and about 20 to 40% of patients with no other aberrant behavior in one study had inconsistent urine tests. So, and this is also part of evolving standard guidelines for treating patients with chronic pain. Some of you already have seen this chart before, but again, this is CDC data showing overdose deaths primarily from opioids, and you can see that any opioid is incredibly high, but also commonly prescribed opioids in the middle line. While it has plateaued, it continues to be a problem, especially in primary care practices, and we are also seeing a rise in heroin and fentanyl. And the question is, like, are we seeing previously people who were taking opioid analgesics being pushed towards heroin and other synthetics because of all the changes that we've been making? This is new data from New York City Department of Health. They have these great data briefs that are available for anyone, which shows in the past 5 years, the age-adjusted rate per 100,000 of overdose deaths by opioid type. And you can see in the bottom lavender line, that's fentanyl between 2014 and 2015. In 2016, fentanyl was responsible for about 44% of overdose deaths in New York, with the greatest need in the Bronx and Manhattan. And the green line is opioid analgesics. So how confident are residents in interpreting urine drug testing? I just show this because, we don't, I think on the whole nationally, we probably don't do a good job of educating our residents. There was a study done in 2012 by some of our colleagues at Montefiore, which basically asked residents these questions and then gave them a quiz to test their knowledge. And they found that 56% of residents felt confident in urine drug testing interpretation. And then when you look at actually how many people failed or passed the test, of the 56% who said they were confident, 73% failed the test. So we have a lot of work to do. And so I just want to quickly go through when you should order tests and how to interpret them in the last 5 minutes. So you should always order urine drug tests before prescribing controlled substances, and then you should do it regularly throughout treatment, which Trang already mentioned. Just to remind you guys, there are natural opiates, semi-synthetic opioids, and synthetic opioids. So codeine and morphine are derived from poppy, and the semi-synthetics are the ones that we commonly prescribe in the clinic, and then the synthetic opioids are fentanyl, meperidine, and methadone. And this becomes important when you're looking at drug screens and what comes back positive or negative. So we have a screening test and confirmatory test. Screening tests are enzyme-based immunoassays. They're very inexpensive, they're fast, they're widely available, but they are susceptible to false positive and false negative results. And the opiate screen is not sensitive for semi-synthetic drugs. So oxycodone may not show up positive on an opiate screen, or synthetic opioids at all. So fentanyl, meperidine, will not show up on an opiate screen. We also have confirmatory tests, which are basically much more highly sensitive and highly specific. They're basically done by gas chromatography and mass spectrometry, or GCMS. They're more expensive, they do take longer, and they're send-out tests. But they really are helpful because they detect drugs that are not reliably detected on the screen. And they report a concentration even if it's low. So there's no cutoff. So screening tests, cheap, inexpensive, but there's a cutoff and there's a threshold. So if the drug concentration is not above that threshold, it will not turn positive. So we have currently at IMA 2 sent out lab screening tests, so monitor 10 drug class and then monitor 14 drug. And then of course we have the urine drug of abuse. This is what the monitor profiles look like, and we just recently implemented them. They're pretty comprehensive, and they have a lot of the most common drugs that we prescribe and also we want to look out for. And so these are the 2 panels over here. And I just want to quickly remind people that you should always order a screening test first and then add on a confirmatory test if you get an unexpected result, right? So don't order the confirmatory test immediately. And then just note the difference in the 2 panels. So the Monitor 14 panel has buprenorphine, fentanyl, and tramadol. GCMS takes about 5 to 7 days to come back. So how do you order it? Step 1, figure out what you're ordering the urine drug test for. So if you're just ordering for pre-employment, please order just the urine drug of abuse, the one that you're used to. If you're initiating opioids or buprenorphine, get the monitor 14. It has everything. And you want that as a baseline. If you're monitoring opioids or buprenorphine, you can get either the 10 or 14, but it really depends on the stability of the patient. So if they're stable on opioids only, get the monitor 10. You don't need buprenorphine or fentanyl unless they're taking fentanyl from you or another doctor. If they're stable on buprenorphine, get the monitor 14 because it has bup in it. And if they're unstable, so they're actively using or you're concerned that they may be using other drugs, get the 14. And then along with ordering these tests comes counseling and interpretation. So just a note about fentanyl. So we don't actually know the prevalence of fentanyl among our patients who are actively using substances and or other drugs in our catchment area and in New York City. Boston Medical Center has been routinely testing for fentanyl for the past few years, and they've actually come up with a prevalence of 10% by immunoassay, which is pretty high and it's scary. And then their positive predictive value of the screen after confirmation is about 86%. And that may be due to other fentanyl analogs and other substances causing a false positive. So if your screening immunoassay comes back positive for fentanyl, please order DCMS to confirm because we don't actually have that data and it can be helpful for our patients. In terms of the language, I usually say as a part of treating your pain with medicines like oxycodone, I order urine tests to get more information about how safe and effective it is. So it's really, really important to say that up front with the patient and let them know this is why you're doing it. You should say the test measures the number of medications and drugs that could interfere with your treatment. And then if I find something unexpected, we'll talk about it and work together to address it. And you can also say this is something I do with all of my patients on these medicines, and it doesn't mean that I don't trust you. So before requesting a urine, you should always ask and document in the chart, when did you take your last dose and how much? In the past week, have you taken any other pain medicine? And in the past week, have you used any drugs? And documenting the above is really critical for interpreting your drug test results. If you find something unexpected, you should keep it open-ended to gather more data. So you can say, I found something unexpected in your urine or your test was abnormal. What can you tell me about it? It's really not a confrontation, and the most important thing to emphasize is that the patients and you should be honest and open with each other so you can work together. These are the metabolic pathways for opioids. So heroin gets converted within minutes in your body into 6-monoacetylmorphine, and then it goes into morphine and then hydromorphone. Poppies also go into morphine and codeine. You'll note that oxycodone on the right goes to oxymorphine, and it doesn't go to morphine or codeine. Okay, and then hydrocodone goes to hydromorphone and then dihydrocodone. Have you guys seen this before? These pathways? Maybe not since pharmacology class. It's been a while. So what if a result is positive for a non-prescribed drug? So it could have been a false positive on the screen, so you should order a confirmatory test. The substance you detected may be a metabolite of a prescribed drug. The patient ingested a drug or a drug that metabolizes to it, and so you should always just go back to the pathway, which is on the guide. And you should really consider all possibilities before acting on a result. What if a result is negative for a prescribed drug? So the urine drug stain, remember, does not reliably detect a prescribed drug, and so this is a possibility for like oxycodone. You should order a confirmatory test. The drug is present, but the concentration is below the cutoff for a positive result. The urine is diluted, there was some tampering, the patient could be a fast metabolizer, or the patient just has not taken the drug recently. And then lastly, the patient could be diverting the medication, or maybe they adulterated the urine. And then valid specimens, really, this comes back on the report as well, but if the creatinine is less than 5, it's not consistent with human urine. And if the temperature and the pH we don't really assess for adequately, it's really just the creatinine that comes back on the report. So if you look, this was developed by Joanna Serrels and her colleagues at Montefiore, and it's a really helpful drug testing guide which goes through all the things I just talked about, including this graph. And so you can see it lists all the drugs and all the testing options, and then what would show a positive or not. And at the very bottom, in the very tiny font, it tells you what some of the most commonly used medications are that may cause a false positive result on the screening immunoassay. So if you, for example, if you ingest like 4 poppy seed bagels a day, your opiate screen may be positive. I'm not gonna talk about detection time. My Top Care also has a urine drug test and interpretation tool, so you can actually click through like, what is your patient taking, what did the screen come back, positive or negative, and it'll tell you if the results are expected or not expected. So let's do some questions together. So in a patient prescribed Tylenol, codeine, and Tylenol number 3, which is codeine and acetaminophen, one would reasonably expect the following to be detected in the urine. So show of hands, codeine, A, B, oxycodone, C, morphine, D, all of the above, or E, codeine and morphine. What do you guys think? Codeine, okay, so A and morphine. Okay, great. So it's A and C, and you can review your pathways and see that if you're given codeine, it can show up as codeine or it can go into morphine. So question number 2. In a patient prescribed MS-Contin morphine, one would expect the following in the urine. A, morphine, B, oxycodone, C, codeine, D, all of the above, E, A, and C. A. Great. So morphine does not go into codeine. It's usually the other way around. Question 3. In a patient using heroin, what would you detect in the urine? A, heroin, B, hydromorphone, C, morphine, D, all of the above, A and C only. E? I can hear E's. Everything? Okay. So it's just morphine. So you guys can look at your pathways. So it really, heroin goes to 6-monoacetylmorphine and it goes to morphine directly. It does not go into hydromorphone. And you would rarely ever find heroin in the system because it gets metabolized very, very quickly. A patient on oxycodone is given a urine drug test. He states that he ate a Popsy Danish for breakfast. What substances might be detected in the urine? A, oxycodone, B, codeine, C, morphine, D, all of the above, E, A, and C only. A, oxycodone. Anything else? So you could potentially see all of the above because of the Popsy. The following are valid reasons for a negative urine opioid screening in a patient on opioid therapy. A, the patient ran out early and has not used in a few days. B, the patient is a fast metabolizer. C, drug screen does not detect that particular opioid. Or D, A, B, and C only. E, A, and C. D? So it's everything. And then a patient on chronic hydromorphone therapy tests negative for opioids on a urine drug screen. He claims to be using the medication as prescribed. The next most appropriate step would be A, subject the urine to a different kind of test. B, re-administer a urine drug screen at the next visit. C, taper and discontinue opioid therapy. D, refer the patient to a detox rehab center. E, notify law enforcement. E? No, just kidding. Yeah, so you want to order a GCMS confirmatory test. So in summary, IMA has safe opioid prescribing guidelines that follow standard practice in an effort to improve patient safety and decrease misuse of an addiction to opioid analgesics for patients with chronic pain. And then urine drug testing should be performed routinely in patients on chronic opioids and can be a helpful tool when ordered and interpreted correctly. So thank you. And I know we're out of time, but please email